Okay, so let's talk about folate deficiency. Where do we actually find folate in nature? Well, we might find it in leafy greens such as cabbages or kale, might find it in chickpeas, fortified bread and cereal, and as well as that we might find it in nuts such as cashew nuts. So you can see the sources of folate are quite large. So just like before with iron, folate makes its way to our stomach and it makes its way directly to the proximal part of the duodenum where it's absorbed into our bloodstream. And into the bloodstream, it has to first be activated. So folate has to get converted into dihydrofolate. And this is done by the action of an enzyme known as dihydrofolate reductase. The dihydrofolate is turned into tetrahydrofolate, which can then be used to make purines, pyrimidines, and this is what we need to make our nucleotides. We might also use the tetrahydrofolate to make things like amino acids. So now that we understand how folate comes in, what could go wrong and how might we become deficient? Well, we simply might not just be eating enough of it, so we might have a reduced intake. This is rare, however, as you can see how varied and how many sources we can actually get folate from. The next thing that we may happen is that we might have an absorption problem. So if you have some disease in the duodenum, something like celiac disease, then we're not going to be able to absorb our folate properly. We might then have an issue activating the folate. So if we have inhibition of the dihydrofolate reductase enzyme with something like methotrexate or a sulfur drug such as trimethoprim, then we're going to have issues utilizing our folate. This is the reason why we should never ever ever prescribe methotrexate and trimethoprim together, as they cause severe bone marrow suppression or myelosuppression, as we simply cannot use our folate. Right, so we have an issue with taking folate into our body. What if we have an increased demand for the folate in our body, but our supply stays the same? Well, if demand exceeds supply, we're going to run into shortages, right? So what might increase our demand? Well, pregnancy, for instance, might increase our demand as we now need to form the cells of the new fetus. The next thing that might increase our demand is an active cancer. So if we have lots and lots of new cells or a tumor forming in our body, that's going to use up lots of our folate stores. And the last thing is something like hemolytic disease. So hemo refers to blood, lytic refers to splitting or breaking down of. So if you're breaking down lots and lots of blood, then we're going to need to form new blood, and this uses up quite a lot of our folate. So we said that we needed purines and pyrimidines to form these DNA precursors known as nucleotides. And we need these nucleotides in mitosis to form genetic material. Therefore, if we don't have enough nucleotides because we don't have enough folate, we are not going to be able to form the genetic material. So our cells won't be able to divide. But they can still grow, and the cells actually get stuck in the growth phase. So therefore, our cells just grow larger and larger, leading to a macrocytosis. Macro refers to large, and cytosis means lots of large cells. So we get macrocytic red blood cells. We also get lower reticulocytes as our hematopoietic stem cell physically cannot divide. As well as this, other rapidly dividing areas, such as that of our tongue, cannot replace the layers it's losing. So therefore, we might get a painful red tongue known as glossitis. We might also get pain on swallowing as we can't replace the layers that we're losing at the back of our throat. So what kind of things and what kind of symptoms are we going to see on history? Well, if you have been watching the video from the beginning, we're going to see exactly the same symptoms of anemia that we've discussed in the previous section. On top of this, in megaloblastic anemia, which is we might see some glossitis like we discussed, and some odanophagia, in other words, painful swallowing. What are we going to notice on examination? Well, on examination, we're not going to notice, again, the signs of anemia, so things like pallor that we discussed earlier. Now let's move on to the most interesting bit. What are we actually going to see on investigations, and what investigations are we actually going to want to carry out? So the first thing in any hematological condition, we're going to want to do a full blood count. Now, because this is a macrocytic anemia, we're going to see a low hemoglobin and a high MCV. We also want to carry out a blood film. And on the blood film, we're going to see macrocytic cells. And as well as this, we're going to see hypersegmented neutrophils. This refers to neutrophils with more than 5 lobes in their nuclei, and this is a hallmark of megaloblastic anemia. We're also going to want to do a reticulocyte count, and we see our reticulocyte count is low for the reasons I've explained before. And lastly, we're going to want to do a serum folate and serum B12 studies, and we're going to see low serum low serum folate. Finally, how are we going to want to manage this condition? Well, if we're lacking folic acid, the best thing to do is give folic acid as it has better bioavailability. So we give 1 to 5 milligram once a day. If our patient is pregnant, however, we might want to give a prophylactic dose when they're trying to get pregnant at 400 micrograms once a day. Great, so now let's have a look at B12 deficiency. So where do we get B12? Well, we get B12 from mainly animal sources, so things like red meat, fishes like salmon, eggs, dairy products, and lastly, for vegans, fortified bread. Now, the absorption of B12 is actually very, very long-winded. So we're going to start with where it all starts, and that's with the release of a protein known as R binder protein from our salivary glands, also called haptocorin. Now, we don't actually bind the B12 at this point in our mouth because the B12 is actually bound to protein. So until we break down that protein, we can't do that. And when the protein makes its way to our stomach, the protein is broken down into amino acids by an enzyme known as pepsin, and this releases the B12. So finally, the B12 can bind to the R binder protein, making a B12 R binder protein complex. But that's not the end of the story, because later on we need another protein, and this is made in the stomach by the parietal cells. And we call this protein intrinsic factor. So just as a quick summary, at the stomach at the moment, we have an R binder protein bound to B12, and we have a release of intrinsic factor not bound to R binder protein, not bound to B12. When it gets to the duodenum, however, the pH goes up due to the release of bile. So the R binder protein now lets go of the B12, and now the intrinsic factor binds to B12, forming a B12 intrinsic factor complex, which makes its way to the terminal ileum, the very last portion of our small bowel, and finally can be absorbed into our blood by enterocytes, the cells that absorb these. In the blood, B12 has a very important role. One, it helps to actually activate folate, and it works alongside folate to help us to produce purines and pyrimidines, which we learned in the last section are involved in making nucleotides and DNA. Another thing to understand is that our body can't actually make some amino acids, and one that it can't make is methionine, which is needed to make the amino acid cysteine. An intermediary to this reaction is homocysteine, which is toxic. B12 helps to convert back excess homocysteine into methionine, thereby reducing homocysteine levels, which is toxic in excess. Another thing we have to understand about amino acids is that we can't actually store amino acids, but we can actually convert them into things like succinyl coenzyme A. We don't have to remember the name, just something that can enter the Krebs cycle. An intermediary to this is methylmalonic acid. And in order for methylmalonic acid to get converted into the end product so that we may use it, we actually need B12 to act as a cofactor. So therefore, you can see B12 has some fantastic and very important roles in the production of not only DNA, but also to help us mop up some of the most toxic products in our body. So if we don't have the production of purines and pyrimidines, we learned last time that our hematopoietic stem cell can't divide. So we get megaloblasts. Not only therefore hematopoietic stem cell can't divide, we get less platelets being produced, so we bruise easily. And as well as that, we make less white cells, so we have recurrent infections. What other sites are affected? Well, what other sites, like we said last time, are rapidly dividing? Our tongue, so therefore we get glossitis. The back of our throat, so we get painful swallowing sometimes, okay? What about homocysteine? Well, homocysteine can actually damage our arteries and go on to give atherosclerosis, increasing our risk of cardiovascular diseases like heart attacks and stroke. And methylmalonic acid actually builds up in our myelin sheath and actually damages the myelin sheath, meaning that we conduct our impulses very, very slowly, leading to a peripheral neuropathy. Think of it like having lots and lots of potholes pop up in the middle of the motorway. You're not going to be traveling very fast. Okay, so what mechanisms might we have into reducing why we have less B12 in our body? Well, we might simply not be eating enough, and a diet that might do this is like the strict vegan diet. We may not be producing enough intrinsic factor. Why might this happen? Well, if we have autoimmune destruction, which is one of the most common causes of this B12 deficiency, if you have autoimmune destruction of the parietal cells, Or if you have autoimmune destruction of the intrinsic factor, then we're going to have less intrinsic factor. And therefore, we're going to be absorbing less B12 inside of our bodies. Now, this is a very specific condition known as pernicious anemia, one of the most common causes of B12 deficiency. What else could go wrong? Well, we could have an issue with the absorption side. So if you have ulcerations in the terminal ileum, like Crohn's disease, or if you had a tumor there that required us to remove the terminal ileum, something like a terminal ileal resection, then we won't be able to absorb the B12. So let's move on to some of the symptoms of this B12 deficiency. Well, first of all, we're going to get symptoms of anemia because we don't have enough blood cells. The next is that we might bruise easily as we're not producing enough platelets, and recurrent infections as we don't have enough white cells. And we might also get glossitis and painful swallowing as we can't replace those layers quick enough. What might we see on examination? Well, on examination, we're going to notice signs and symptoms of anemia. The next thing we might notice is a slight yellowish tinge to the skin, as the blood cells we are producing are fragile, so tend to get broken down in the spleen, releasing lots of bilirubin. This can cause our skin to turn yellow. The next thing we might notice is impaired sensation due to us damaging our myelin sheath. In fact, it specifically tends to affect the sensation that deals with vibration and proprioception senses. And if left for long enough, we might get a condition known as subacute combined degeneration of the spinal cord. What else might happen? Well, if we can't tell what's around us because we've got loss of our vibration and proprioception senses, we can't see when our eyes are closed. We can't walk with our eyes are closed. So therefore, we don't know what's around us. So when we close our eyes and we push the patient, they almost fall over. This is known as the Romberg's test. As well as that, we might see a hyperreflexia, so all our reflexes are very, very pronounced, except for the ankles where they may be missing. What kind of investigations will we want to carry out? Well, just like last time, our bread and butter investigation is going to be a full blood count. And just like last time, we're going to see a reduction in hemoglobin and a macrocytosis because we're getting megaloblast production. As well as this, we might see a pancytopenia. Pancyto refers to all of the cell lineages of the hematopoietic stem cell, and penia a reduction of, so thrombocytopenia and leukopenia. We want to do a blood film too, and we will see macrocytosis once again because of the megaloblasts, and we will see hypersegmented neutrophils as we did in the folate deficiencies. Now, with the yellowing of the skin, this sounds a little bit like hemolytic anemia, so we have to rule this out. And we do this by doing a reticulocyte count. And typically in B12, we see a low reticulocyte count, when it's hemolytic, they're high. Also, when we check our B12 and folate levels in the blood, B12 is reduced. We might also want to check our methylmalonic acid levels because remember, B12 helps to reduce methylmalonic acid. So within its absence, methylmalonic acid levels might be high. Lastly, we want to check antibodies against intrinsic factor or antibodies against gastric parietal cells. And if we detect these antibodies, we know this is likely to be pernicious anemia. Okay, so what do we want to do in terms of management? Well, if we are missing vitamin B12, the best thing to do is replace it. And we do this with intramuscular IM cobalamin, which is the chemical name for B12. The reason we do this intramuscularly is to make sure that it truly gets into the bloodstream, because if they have pernicious anemia, there's no point of giving it by mouth. Lastly, a good thing to mention is if the patient has both B12 and they have folate deficiency, always replace the B12 first. A good way to remember it is to go B before F. Thank you for watching part 2 of Haematinics. I've included some questions here, so please feel free to pause the video and check out the questions and have a go at them. I'll include the answers down below as well. If you have any further questions, do let me know and I'll try to get back to them as soon as possible.